be presenting about clinical and radiological features of neurocysticercosis and its treatment. My moderator is Dr. Soumya and I myself Jothivannan. We will be going through introduction, pathogenesis, diagnosis, radiological features, and treatment approach to the neurocysticercosis. Introduction: neurocysticercosis is most common parasite infection of the brain, and it is leading cause of preventable epilepsy worldwide, accounting for up to 30% of the epilepsy cases, where it is endemic. The prevalence in India is calculated to be approximately about 1 per 1,000 population. This is the geographical prevalence of Tinea solium infection, which is published by WHO in 2015 in the edition of Neglected Tropical Diseases, which classifies India as endemic region. They are classified as most of the tropical countries come into endemic regions, and there are the countries which not fall into tropical countries but still have this infection, mostly due to imported cases, where it is due to possible human cysticercosis transmission. The data about Indian prevalence is not available, although in 2008 there is a study which was published regarding the geographical prevalence of Tinea solium infection, and this was published in 2008. In that, the cysticercosis seems to be widely endemic in North India, especially Bihar, Uttar Pradesh, and Punjab, where incidence is quite low in Kerala and Jammu Kashmir. But it is still in the rising trend. Pathogenesis: the causative agent is Tinea solium, and it can cause two different kind of infections. It can be either due to teniasis or cysticercosis. It is based on which infective form you are going to intake. If you are having a food infected with adult worm, then you will have GI manifestations. But if you consume in a larval form, it can affect any organ. Teniasis: the intermediate host is the pig and definitive host is the man. In cysticercosis, the accidental host is the man. The most common site of cysticercosis is the brain, followed by eyes, muscles, and skin. The route of transmission, it is most common, is not due to the consumption of. Yes, sir.
Explain accidental posting. Accidental but definitely. What comes there? What breaking?
The root of yes. The route of transmission, it is mostly fecal oral contamination is the most common by ingestion of Tinea solium eggs directly from the carriers, and also autoinfection by adults harboring adult parasites in the intestine. The factors which favor the transmission are presence of Tinea carriers, inadequate disposal of human feces, free-roaming pigs having access to the human feces, consumption of undercooked pork, and illiteracy, poverty, and poor sanitation also plays a part in this transmission. This is pathogenesis of cysticercosis infection. Once eggs or gravid proglottids in feces passed into environment, the pigs consume it, and the infective form is oncosphere. Once after digestive system, these oncospheres hatch and penetrate intestinal wall and enter into multiple organs, where they can cause infection in GI infection, and the humans can pass this in the environment back. This in the larval form, if human consumes it, it can also penetrate and enter the circulation and cause cysticercosis. In pig, this circle is called porcine cysticercosis. If it affects man, it is called human cysticercosis.
What if the man just egg?
If-
What if the man just egg? What if the man just big tree? Two different things will happen. Suppose a human being happens to eat the egg,
Yes, sir.
contaminated vegetable, something like that. Or there's one way, somebody is consuming under the form. So in what way you put the what kind of egg they can take? Okay. That is the way to people.
If they are going to consume eggs, there is a high chance that it will have dissemination and cause cysticercosis, and it can disseminate, sir. When they are going to consume the adult form, that will stay only in GI tract.
Look at that.
This is will convert into oncosphere and it will enter the circulation. Oh.
That is the duty of that is the way that I think. There is a difference when somebody ingest that, then keep the egg form. Word of the entire study, subject the meat. Actually, without those, the book.
X will lead to cysticercosis, sir. Cyst will lead to tinea. These are the different growth stages of tinea solium, where these are the eggs, which next grow into cysticercus. The cysticercus, after growing, it leads to evagination, and the head of the scolex will form. And this is the head of the scolex under microscope, and they get elongated.
What for it? That is what for it.
Then this is tape form strobila. So pathogenesis, once once in digestive tract, eggs evolve into oncospheres and carried into bloodstream and CNS and other tissues. Once it enters the brain, it is called vesicular stage. And once cysticercus reaches its final location in brain parenchyma, a period of several years or months usually follows. Larval form, sir. Then it will convert into oncospheres.
Larval forms.
And once it is in the final location in brain, it takes several months to years to follows until onset of symptoms. And parasites evade the immune mechanisms of body through humoral and cellular pathways. No, sir. It can affect any organ.
Why there is a potentially golden organism?
Not sure.
Okay.
The humoral mechanism, the cyst, once entering the circulation, they can cover themselves with the host antibodies by absorbing antibodies through special receptors. This masking hides them from immune attack. And they also have enzymes like teniastatin and paramomycin. Teniastatin blocks complement activation by enzymes, and it blocks classical and alternative complement pathways. And paramomycin binds with C1q and inhibits its action. And these lyses also release proteases such as cysteine proteases, metalloproteases, and serine proteases, which breaks down host antibodies. In cellular mechanisms, the parasite causes type 2 immune response, which produces regulatory chemicals like TGF-beta and interleukin-10 to reduce inflammation. And it also has special antigens like excretory secretory antigens, which can disrupt balance of CD4 and CD8 cells, favoring immune evasion. And it also stops dendritic cells from maturing, so they can't activate the other immune cells, and also turns macrophages into less aggressive forms, which produce again TGF-beta and interleukin-10, which suppress multiplication of immune cells. The cysticercae begins to degenerate either naturally or due to anti-helminthic treatment and lose ability to regulate the host response after some time. And as a result of the immunological attack from the host, it enters a process of degeneration, and that ends with the death of the parasite and its transformation into mineralized nodule, that is calcified stage. And there are two intermediate stages, which is called colloidal and granular. So pathogenesis.
What they want to first stage is study. So they are different radiological, they are different how they behave biologically. They are different, they are immune response. So how the all the four forms are different.
I have slides, sir. Pathogenesis. In vesicular cyst, it produces excretory vesicles, excretory secretory proteins. It produces all these enzymes, which will inhibit both humoral mechanisms and cell-mediated mechanisms. So it evades from the immune system. At colloid cells, they decrease the ability to produce these enzymes. So the immune response starts to act, and there is production of cytokines and predominantly substance P. The substance P, the importance I will speak later. And in granular nodular cyst, the cyst, once it undergoes the immune action, it starts to degenerate and decreases smaller in size. And in stage 4, and here the granuloma formation starts. In stage 4, it becomes calcified cyst. There are 4 stages. Vesicular stage. All 4 stages are depicted in the same picture. In stage 1, there is a viable parasite with no reaction. In stage 2, there is it is an active form with cyst fluid will be turbid, and there will be leaky membrane, and it is the most symptomatic stage. In stage 3, edema will decrease and cyst will retract, and in 4, it will become calcified. Yes, sir. The clinical features will depend on mainly 4 parameters, whereas number of cysts, the size of the cyst, location, and intensity of the host immune response. The major determinant among the 4 is location of the parasite, whether it's brain parenchyma or extraparenchymal spaces. Intraparenchymal cysticercosis has a better prognosis, whereas extraparenchymal has the worst prognosis, with mortality rates in some studies goes up to 20% if untreated. And subarachnoid and intraventricular neurocysticercosis are under extraparenchymal. They are known to have produce high mortality and morbidity. And patients with one brain lesion have good prognosis with no seizure relapse, whereas many cysts in the brain can lead to recurring seizures. Neurocysticercosis can be divided into intraparenchymal and extraparenchymal. Intraparenchymal is the most common, up to 60%. Extraparenchymal is 40%. The most common manifestation is seizures and focal neurological deficits, meningitis. In extraparenchymal, it can be intraventricular, subarachnoid, spinal, orbital, ocular lesions. Seizures. This is the most common clinical presentation of neurocysticercosis. It occurs into 80% of the symptomatic infections, and most common it is parenchymal and most commonly seen in granular or calcified lesions. And most common type is focal seizures with secondary generalization. In patients with granuloma, the seizures occur as a result of breakdown of a blood-brain barrier resulting in inflammation related to attack of host immune system on previously viable cyst, whereas in calcification, the seizures are due to intermittent liberation of cysticercal antigens trapped within these calcified nodules. This is an image which I took from neurology journal, where it is that occurrence of seizures in different stages. Most commonly, it starts from early colloidal stage and late colloidal stage, where it is most symptomatic form. And it is also seen, it can be seen in any stages, but it's most commonly seen in here in colloidal and mostly granular stages. The relapse is most common in patients with calcified neurocysticercosis with up to more than 50%. But the risk of recurrence, risk factors for recurrent seizures are found to be female, calcified lesions in the temporal lobe, seizures in year before the first evaluation, more than 10 lifetime seizure episodes, and abnormal interictal EEGs. Focal neurological deficits are seen in 5 to 15% of the patients, and it can cause almost any focal neurological deficit of central origin. And due to presence of it can be due to presence of parenchymal brain cyst or the effects of pericystic edema or mass effects. And these manifestations are usually subacute to chronic course and most frequently observed in patients with subarachnoid cyst compressing the brain parenchyma. The focal signs and ischemic strokes related to occlusion of small and medium intracranial arteries are reported, and stroke syndromes occur in about 3% of patients with neurocysticercosis. Radicular pain, weakness, and sensory deficits are common in patients with cysticercosis of spinal cord, and entrapment of cranial nerves also reported, leading to paralysis of extraocular muscles, hearing loss, facial nerve palsy, and trigeminal neuralgia. Yes, ma'am. Yes, ma'am. Intracranial hypertension, the most common mechanism of in hydrocephalus due to cyst or inflammation, causing mechanical blockage or communicating hydrocephalus, which is frequent in neurocysticercosis arachnoiditis. The clinical course of intracranial hypertension and hydrocephalus secondary to basal arachnoiditis might be subacute to chronic. Hydrocephalus related to fourth ventricle cyst might present with Bruns syndrome. And mass effect with intracranial hypertension can also develop secondary to large subarachnoid cyst or cyst clumps, which frequently develop in Sylvian fissure or basal systems of the brain.
What's
I have a sudden onset headache, vertigo with positional change. Sir. Because Colloidal cysts. Or sudden onset. Intracranial hypertension might also be due to so-called cysticercotic encephalitis. It is a severe form of parenchymal neurocysticercosis. In patients with cysticercus encephalitis, have hundreds of small, viable, and degenerating cysts with a diffuse inflammatory reaction. And hydrocephalus in neurocysticercosis is associated with high mortality rates. Headache can present even with or without intracranial hypotension, and it is mostly seen in patients with calcified lesions. And it is found to be 5 times more prevalent than with the age-matched controls. The mechanism of headache, which is proposed, is once release of trapped cysticercal antigens, this will release inflammation, a brain edema, and rupture of a blood-brain barrier, which liberates the free radicals and oxidative stress, which can cause breakthrough seizures. The one of the main substance which is shown to cause this seizures is substance P. Substance P is convolescent, which causes seizures. And also this free radicals causes upregulation of calcitonin receptor, CGRP peptides, which stimulates the trigeminal reflex and cause migraine attacks. Intraventricular lesions. The cysts lodge in ventricles and cause mechanical obstruction. The fourth ventricle is the most frequently involved. Also, the other ventricles can also be involved. And unattached cyst can cause sudden positional mechanical obstruction, causing nausea, vomiting, vertigo, which is called Bruns syndrome, and more indolent. And it also can present with symptoms of nausea, headache, vomiting associated with hydrocephalus. Subarachnoid lesions based on the location can have different presentations. If it is at the brain convexity, it behaves like an intraparenchymal cyst. That is, it presents all 4 stages. It is present at sylvian pressure. It will present with cystic clumps and giant cysts resulting in mass effects. If it is in basal cistern, that form is called racemose neurocysticercosis. It is the most severe, is due to basal subarachnoid NCC because of its location and ability to expand and multiply. Racemose neurocysticercosis is an aberrant proliferating cystoid larva and resembles bunch of grapes. So it is called racemose. And it typically lacks colex, contrast enhancement, and or edema. And the inflammation directed at the parasite in the arachnoid space affects the meninges, brain, and can cause focal or diffuse arachnoiditis of the brain and spine.
Where you get
Staphylococcus. The meningeal inflammation and leptomeningeal thickening at base of the brain can lead to visual field defects and cranial nerve palsies due to entrapment of cranial nerves arising from brainstem. Spinal cysticercosis is present in 1% of the population, and it is usually seen, located in subarachnoid space where they can cause inflammatory or demyelinating changes and present with radicular pain, paresthesias, and bladder disturbances. Orbital lesions, it most commonly it affects the extraocular muscles, which is seen in 69%, and subconjunctiva. And intraocularly, it can affect vitreous cavity 8%, anterior chamber 4%, and subretina is only 4%. Since retina is a neural tissue, presence of subretinal cyst reflects neurocysticercosis. And the symptoms include impaired vision, recurrent eye pain, diplopia, and masses. The diagnosis is mainly based on neuroimaging, CT and MRI brain, and immune diagnostic tests like ELISA, EITB, monoclonal antigen-based assays, and quantitative RT-PCR. So currently, these lines are taken from WHO 2021 guidelines, where now MRI is the tool of choice in diagnosis of neurocysticercosis. When when parenchymal viable, parenchymal granuloma or any other locations like cerebellum, brainstem, ventricular, subarachnoid, and spinal spaces are suspected. So now CT is only for calcified lesions. If you suspect intraventricular or subarachnoid space, then you have to do MRI with 3D volumetric sequencing. In all other cases, we can do MRI. The MRI imaging sequences with characteristic appearance. In T1, the contents will be hypointense and Scolex, it is used for Scolex identification. T2, the contents will be hyperintense. In FLAIR, we can see inversion of the contents. DWI is used for identification of Scolex and degenerating lesions. And SWI is used for Scolex and valve characterization. CIS3D is used for subarachnoid or intraventricular lesions. Post-contrast T1 is important because it is used to see ring enhancement. Vesicular stage. In this stage, this is the T2 axial image, which is showing hyperintense inversion. It is hyperintense cyst with hypointense wall. And on inversion, it is showing hypointense contents with hyperintense rim. There is no edema or no post-contrast enhancement. This is vesicular stage. Colloidal stage. This also has hypointense with hyperintense Scolex. In T1 images, sorry. In T2 images, we will have hyperintense cyst with hypointense rim and Scolex. But characteristic of this is the presence of edema. And in colloidal stage, T2 FLAIR shows inversion of cyst and contents. In granular nodular stage, there will be no inversion of cyst contents in the FLAIR sequence. And even peridema is found in granular nodular stage also, it will be less compared to the colloidal stage. No, sir. And calcified lesions can be seen in normal CT. So imaging, we have 4 stages: vesicular, colloidal vesicular, granular, and nodular calcified. Vesicular will have no no rim enhancement, and in T2, contents will be hyperintense. The contents will be hyperintense. In FLAIR, it will be hypointense. So in nodular calcified, it is easy because in CT, we will have small lesion. Vesicular, we have no edema or enhancement. So the difference will be between colloidal and granular. In colloidal, in T1 post-contrast, there will be a thick rim enhancement and there will be edema formation. Edema will be there, which will be less in granular, and T1 post-contrast will be less prominent in the granular stage. In flare, we will have no inversion of contents will be there, madam. Here it will be inversion of contents will be there. Here there will be no inversion of contents. This is a sign which is seen in neurocysticercosis, which is called corona sign, where in T1 post contrast, the cyst will show hypointense cyst with isointense rim and edema. It represents like it mimics the corona of the sun, solar corona, so it is called corona sign. It is usually seen in acute cases. Post contrast MR, sir. Post contrast T1 post contrast, we will have this in the acute cases, acute symptomatic stage.
What stage?
Usually, it is seen in the second stage, sir. In colloidal, early colloidal, we will have this sign.
The last one, like a big technique, that is created. Describe it. How do you appreciate what the people?
That's
You have to for corona, post contrast or flare or
in T1 post contrast, sir.
that is post contrast.
Yes, sir.
But the other frequent for the showing some corona. Everything is post contrast. Polar post contrast.
Extraparenchymal locations. This is subarachnoid neurocysticercosis, which is showing in T1 conglomerate lesions. This is racemose cysticercosis, which is in the which is resembling grapes, bunch of grapes pattern. And this is cysticercal encephalitis. This disseminated cysticercosis is defined when there is more than 20 lesions in the brain, and cysticercal encephalitis. Intraventricular, no. Extraparenchymal lesions, this is subretinal neurocysticercosis, and it can also affect parts of the brain, like in this disseminated neurocysticercosis is present in the thighs. Most common is brain, madam. Brain, eyes, muscles, and skin.
Why and how answer, do you know why?
No,
Election for
no, madam. Skin also.
Like,
I'm not sure. Solitary cysticercus granuloma. This term was introduced by Indian Rajashekar et al. In 1993, and it is considered as the most frequent type of neurocysticercosis in India and Asian countries. And it is a neuroimaging abnormality. A patient presents with epilepsy, new onset epilepsy. If you take an imaging, and it is showing a single cysticercus granuloma, and it most probably it's closer to granular nodular stage, and it's usually less than 20 millimeter in diameter. So the diagnostic criteria for solitary cysticercus granuloma is new onset seizure, a patient presenting with new onset seizure, absence of increased ICP, no progressive neurological deficit, and no evidence of systemic illness. And you do a CT, and the CT shows solitary ring enhancing less than 20 millimeter lesion with mild or moderate perilesional vasogenic edema. This can be characterized as solitary cysticercus granuloma. The natural course is it will have complete spontaneous disappearance of the lesion will happen. but in 20 calcified residue is seen in approximately 20% of the patients. And many studies suggest that this resolution happens from 6 weeks to as late as 75 weeks. And a study which included 210 patients observed that at 3 months, 19% had complete lesion resolvement. At 1 year, 63%, and mostly by 89% had lesions disappearance within 2 years. Immunological diagnosis, EITB, enzyme-linked immune electrotransfer blot. It is an antibody detection assay. It is 100% specific for Taenia solium infection. The sample which should be taken is serum sample rather than CSF sample. And it has when there are more than 2 cysts, it has 100% specificity. Whereas when it is a single cyst only, it has only 50% of the 50% specificity.
Does it happen in the skin?
Sir?
Before the infection is not what is the body. What happens to the body? Yeah, right.
No, sure. The newer modalities are monoclonal antibody-based antigen detection assays, which are licensed in Europe, not available in India. And it uses serum sample sampling. CSF is better than serum sample in this for this test. But negative serological test does not exclude the diagnosis of NCC. With compatible clinical manifestation and radiographic findings. Molecular testing, quantitative RT-PCR for Taenia solium DNA is highly specific and sensitive. The CSF sample has high specificity and sensitivity. And newer modalities which are coming are metagenomic next generation sequencing. And this is comparison between all 3 tests. EITB has overall, it uses antibody detection, and it has overall 86% sensitivity and 100% in multiple lesions. And it is current gold standard in CDC and reference labs. Limitations is single lesions, it has low specificity, and also calcified lesions. ELISA is also used antibody detection, but its sensitivity is only 41%, and WHO recommends not to use a ELISA-based test. And it is very simple to perform, but has high false positive and negatives. Antigen detection assay, it can test in all 3, CSF, serum or urine. It is less sensitive, but it correlates with viable cyst burden. And it is used for monitoring treatment response, but not commercially available in US, and lower sensitivity than EITB. In India, we have only IgG, 60 circle IgG antibody, madam, which is available in Lalpath labs, which is 1,500 rupees. That EITB, I could not find where it was there.
Last 3 years, have you ever ordered for this instance? So what are they doing? The patient is not sure if it was what kind of lesion. Tuberculosis that will get possible. And what is the cause of the false positivity? What is the consequence? Practically, I don't think that it's not useful anywhere to make such leaderships to be human very that just to be
CSF findings. Yes, ma'am.
That was available. Available. Being followed. Not available.
CSF findings. If it is parenchymal lesions, it usually demonstrate mildly elevated WBC and normal glucose and protein concentrations. If it is in setting of arachnoiditis or ventriculitis, there will be marked as a protein elevation and decreased glucose concentrations can be seen. Usually, it will be have mononuclear predominance, but neutrophils and eosinophils also will be present. Diagnostic criteria. This is called Del Bruto's criteria, which was given by Del Bruto, who is in the Ecuador. And absolute criteria, the diagnostic criteria is classified into absolute, neuroimaging, and clinical or exposure criteria. The absolute criteria, you need only one out of these three to diagnose neurocysticercosis. The three are histological demonstration of parasite in biopsy, in brain, spine, or spinal cord lesion, visualization of subretinal cysticercosis, or presence of scolex with cystic lesion. Scolex without cystic lesion will come in major neuroimaging criteria, and enhancing lesions, multiloculated cystic lesions, or parenchymal brain calcifications. All these four come in major neuroimaging criteria. And confirmative neuroimaging criteria is resolution of cyst with cysticidal drug therapy, spontaneous resolution of single small enhancing lesions, migration of ventricular cyst documented on sequential neuroimaging studies. Minor neuroimaging criteria will come in the obstructive hydrocephalus. Major clinical exposure criteria is a detection of specific anti-circle antibodies or antigens by well-standardized immunodiagnostic test, or presence of cysticerci outside brain CNS, or evidence of household contact with Taenia solium infection. Minor clinical exposure criteria will be clinical manifestations suggestive of neurocysticercosis and individuals coming from where it is endemic. For definitive diagnosis, you need one absolute criterion or two major neuroimaging criteria plus any one of clinical or exposure criteria.
Where is Ecuador? Okay,
Which part of the world?
Endemic in the tropical countries like India, Peru, Ecuador, Peru.
where is Ecuador?
No, not very good.
Latin America.
What is the doing of India and
Where is Caribbean? North America, South
where
America.
is Brazil? I don't have a phone.
First name whether endemic, Ecuador is endemic for
Ecuador is endemic, sir. India.
where is you from? Peru.
I think Tamil name only, sir.
What is the fully, that is my type of evaluation.
Please stand for.
No.
Do not know where it belongs.
Is it near to Peru?
Where there is an aspect and it's written individuals coming from all regions in India that the process and it is that aspect. But please So we have covered it with an orange color there, but it would have been there. She put some hands on one hand.
The treatment, the guidelines and management were published by WHO in 2021, and also it's published by IDSA and in American Society of Tropical Medicine and Hygiene. The initial approach should be against like a management of acute symptoms rather than treating with antiparasitic therapy. Management of ICP, when there is a patient with diffuse cerebral edema, we have to start on corticosteroid therapy, usually dexamethasone 0.2 to 0.4 mg per kg. If it is an obstructive hydrocephalus, surgical approach is warranted via removal of by drain or shunt. In case of communicating hydrocephalus, by fluid diversion or ventriculoperitoneal shunt or third ventriculostomy. Antiparasite therapy is contraindicated in patients with signs and symptoms of elevated ICP, regardless of the cause. Seizures, even a single lesion will have serve as a nidus for recurrent epilepsy. Most reports of management of seizures in setting of NCC describe the use of phenytoin or carbamazepine. Newer therapies, levetiracetam, also likely better tolerated. Withdrawal of AEDs, if there is a single lesion and if last seizure is 6 months back, then patients can be considered for withdrawal of AEDs, but it should, given that they have low risk of seizure recurrence, like defined as resolving granuloma, no residual calcification, or who are seizure free. AEDs should be continued up to 2 years in patients with single or multiple calcified neurocysticercosis and epilepsy. Before initiation of
the calcium release and it happens. It happens to more than that's fine.
Okay.
It becomes a and they become it's very difficult to identify the calcium that within the parasite. So we use a stereotyping one and all such things. It's very difficult. So these are all lifestyle change. Most of the times, this is there in the journal timelines and then. Not so it is more often.
Right?
Yes, sir.
These 2 years and all is a very general statement, not applicable. That is gradually is going to be there, 99.9% of people, not going to go away. Such things should not be done to people, and changing the medication. Medical and government of people all are old type things.
Before initiation of antiparasitic therapy, 3 things should be seen. First is like ophthalmological evaluation should be done to rule out ocular cysticercosis, because if there is a patient with ocular cysticercosis and we start on antiparasitic therapy, it can cause inflammation and threaten the vision. And patients who are going to be on long-term corticosteroid therapy should be screened for latent TB, and also screening for strongyloidiasis should be done. The benefit of antiparasitic therapy, it fastens the resolution of active cyst, diminishes seizure risk, and reduces likelihood of recurrent hydrocephalus. Antiparasitic therapy should be warranted only with the patients with viable or degenerating cyst on neuroimaging, and it should not be administered or contraindicated in cases where there is untreated hydrocephalus, diffuse cerebral edema associated with numerous parasites, and presence of calcified lesions only. Steroids should be given before and during the antiparasitic therapy, usually at least 1 day prior to the start of antiparasitic therapy. Usual doses prednisolone 1 mg per kg or dexamethasone 0.1 mg per kg. In case of cysticercal encephalitis, the higher doses like 0.2 to 0.4 mg per kg per day can be used. These are the guidelines which are taken from IDSA, which is this was released in 2018.
What is the medication that you use? What are the other options? Number one choice, other options where what other all that we have to
in case of parenchymal cyst, viable parenchymal cyst, if it is 1 to 2 cyst, we have to give monotherapy with albendazole. This is for 10 days. If it is more than 2 cyst, we have to give a combination therapy with albendazole and praziquantel. And anti-inflammatory therapy and anti-inflammatory therapy should be given along with whenever we are giving anti-parasital drug. But if patient is not having any seizures, we should not be giving prophylactic anti-epileptics. Dosage is albendazole, which is 15 mg per kg. BD dosing, the maximum per day in 2 daily dosage, and maximum dose is 1200 mg per day for 10 days. In viable cyst, it is 10 days. Or praziquantel, 15 mg per kg per day in 3 daily doses for 10 days. In more than 2 cysts, it is a dual therapy is warranted, madam.
Guidelines has to be followed, sentence rate. So you don't start a practically in fill up the plan.
In viable parenchymal cysts, in single lesions. We have seen like single enhancing lesions, albendazole therapy is warranted for 1 to 2 weeks. Solitary cystic granuloma, it can be treated with albendazole, which is up to 1 to 2 weeks. Same as above, like if a patient is not having seizures, no need to give prophylactic anti-seizure medications. And in this solitary enhancing lesions also, we have to give steroid therapy.
How do you approach that? Most important thing, and the person sitting in Kerala, we don't get to see all the mental time and answer the low things, but it's a good small and thankful. That's what is people now that are now how do you approach that?
If single enhancing lesions are there, we
the very small is very important. To watch diameter, it is beyond that is to the problem.
Less than 20 millimeter is neurocysticercosis, madam. More than 20 is tuberculoma. Then specific and other associated. And other associated clinical symptoms like patient presenting with meningitis and other.
One or more than one teaching.
Okay.
What is can be wanting to do some. Because so that it will start antiparasitic treatment. With steroid or without steroid?
With steroid, any antiparasitic therapy should be given along with steroids, madam. Because if we start antiparasitic therapy, there will be this antiparasitic therapy will cause inflammation. In patients with this inflammation, it can cause multiple symptoms. So decrease the inflammation. The degeneration. It cause degeneration and it will release all this. We
Whatever we take that is so this is that thing is inflammation. Not that your tramples inflammation. So to counter that inflammation, you can give up on most of your
okay.
You know, that it should be under a supervision. The time you will start all this and send the patient away. When we come back to the earlier seizures or even in brain. That is not warranted. You are moving the treatment. Better keep the patient with the more and do all. To give anti-parasitic treatment with allergen for undercover steroids, anti-star on anti-seizure medications. If the patient presents a seizure, patient patients from the heart without, as I said, how do you infect the small and have to take the lesion? Anything else on that?
No, in calcified.
Stage how you approach the problem, that has been better idea and that can take the context. You yourself do not know.
What is the rest?
Okay, sir. Recurrent neurocysticercosis. No. No. Yes, ma'am. We have here. In subarachnoid lesions, it usually cyst doesn't respond well with the typical doses and duration. So it is given prolonged administration of albendazole even for months, or combination therapy with albendazole and praziquantel. We have to give for the subarachnoid lesions. Intraventricular lesions. If it is we have to see whether it is in lateral ventricle or fourth ventricle, sir. If it is in lateral ventricle, so it's in third ventricle, endoscopic approach is warranted, sir. If it is in the fourth ventricle, microsurgical cystectomy is done. And if it is not amendable to surgery, we can go for shunt or CSF diversion.
What is the response? When you look at the response to that. Try to pull it out. What is happening? Because you have part of the brain on Spanish, what are they?
Okay.
Okay, the zero is coming to the future. Trying to compare to like face and then go for them. Carry concept for
it should be considered as yes, ma'am.
And severe pain and all, you
you finish off the treatment, it's like, and go back to the email, and then that case, or you finish treatment. Not to play.
In this slide, recurrent neurocysticercosis is not uncommon in NCC. It is usually occurs usually occurs within 3 years of initial. And special populations, children with neurocysticercosis, the IDSA is saying like only dosing should be based on weight based. Other like drugs, it is same as for adult population. But Association of Child Neurology Consensus Guideline India in 2021 pediatrics, they say what are the different points they have which is not present in IDSA guidelines is for persistent lesions. They're saying retreatment with same dose and duration with albendazole or concurrent administration of albendazole and praziquantel can be done for multiple lesions. And for cysticercal encephalitis, they give the dosage, which is methylprednisolone and methylprednisolone 10 to 30 mg per kg for 3 to 5 days and dexamethasone 3 to 6 mg per kg for 3 to 5 days. And no role for routine anti-seizure prophylaxis if patient is not presenting with seizures. And if okay. So, 2 slides.
What will you do with that standard if it has a plane? What will you treat?
In encephalitis, first we have to treat for anti-edema only, sir. First is corticosteroid should be given. In cysticercal encephalitis, we have to reduce the inflammation. For that corticosteroids. Once corticosteroids are given and the edema and other edema is controlled, then only we can think about antiparasitic infection, sir.
Suppose the patient is coming with a headache, and when you evaluate the two patients, there is the bloated stage, suppose within the family, no positive, no patient, no right state, no pertaining to the money. How do you think?
Two lesions are there. We have to give for albendazole monotherapies with along with steroid should be given, sir.
Or
Sir?
let us read it.
No, sir. We have to give drug treatment if it is two cysts and which are in active colloidal stage. We have to go for albendazole monotherapy along with corticosteroid treatment. If patient has seizure, you have to give anti-seizure medication. Or no, if it no seizures, no anti-seizure medication is warranted, sir. And patients who cannot tolerate oral steroids, methotrexate is an alternative agent and steroid sparing agent. Because like long doses of steroid is used in subarachnoid NCC. The initial dose is 7.5 weekly.
Information or does the cat take it still in? Or both? How does it end?
And in patients with HIV and AIDS, it should be treated as same as like patients who are not having HIV and AIDS. And albendazole and praziquantel has no renal or hepatic dosage adjustments. So can be given in CKD and CLD patients. 15 mg per kg per day. 15 mg per 50.
Like it is sure that in one place or both. Based on both the teams, right? What is the strength of tablet for a tablet which is available?
400 mg. And follow-up should be done every 6 months. And if there are persisting lesions, a repeat course of antiparasitic therapy is warranted, but the grading, the strength of recommendation is grade 2C. And for prevention, there are two drugs are there, which is niclosamide and praziquantel. Niclosamide is at adults 2 gram, whereas children more than 34 kg is 1.5 gram, less than that is 1 gram. Praziquantel as 10 mg per kg. No human vaccines are available, but in India there is for porcine cysticercosis, there is a vaccine which is licensed.
Vaccination?
Pork, sir. Yes, pigs. Pigs, it is available, but not for humans.
How do you, consider how the,
Patients who are in
there is some problem. And so, I get the,
thanks.
one, how many, and that is the problem.
Prophylaxis is where like patients who are in endemic regions where like a cysticercal like incidence is high, mass chemoprophylaxis can be given, madam. In the two drugs are niclosamide and praziquantel. Annually dosing, I'm not sure, madam. I didn't find dosing. Kiniasis by stool examination.
Anything for the long, but I don't know, the area. Yes.
Hospital built over first. Usually highlighting that is consistent for lack of clarity in OEM level, but lack of clarity in player. Whenever you highlight something, you should know everything about it. Because people might ask.
Okay.
The cost of the wages from radiological department, they have based on that. How should I?